Thank you so much, Greg, and thanks to you and Jenny and the myeloma crowd for having me here today. Yeah, great. So these are my disclosures. So what I wanted to talk about today was what do we consider some of the worst risk multiple myelomas? So you've already heard from several other speakers about double hit myeloma, and what we're talking about there is that there's the TP53 mutation, which is a tumor suppressor gene, and when people have 2 copies of those, or they have one of those and one of another type of abnormality called amplification of 1Q. So those seem to be the worst of the worst double hits, and that is one category that I'm not going to go into great detail today, but the survival has been quite poor with those. So I'm going to talk about these 2 entities, plasma cell leukemia. So leuc means white, and emia means in the blood. So what we're talking about there is that the plasma cells are in the blood, and you're going to say, why are they in my blood? They're supposed to be in my bone marrow, and that's exactly the point. That's the problem. And the second one, I'm going to call it aggressive extramedullary plasmacytomas. In relapse, actually, as relapse, those are extremely difficult, or as refractory even, primary refractory, when the disease hasn't responded to anything. So in that case, tumors form everywhere, and they're not at all related to the bone or the bone marrow in many cases. So the way I've tried to pictorially represent this is that the myeloma cells leave home, leave their home, which is the bone marrow, and they go everywhere. So this is the big problem. So what do the myeloma plasma cells look like? So here they are. They're the cells here with the nucleus and a lot of cytoplasm, and they're all over this bone marrow. And this is how they normally live. So when we do the bone marrow biopsies and we look for them, this is where we find them. And this is a lower power, so it's under the microscope, and you see all these cells. They're just teeming in here. They're crowding out all the cells, but here they're living in a bone marrow cavity. This area is full of fat, and this is within the bone. And this is where it's normal for them to live. When they're living in that bone marrow, they're actually behaving some of the signals that limit growth. So when you think of cancer, you think of it having unlimited expansion and growth. And when they expand in the bone marrow, that's how fractures happen. When they expand and they form, or they even can expand into tumors that are kind of fixed to the bone. But what happens in plasma cell leukemia is they no longer live there. They actually fill the bloodstream. And the definition of plasma cell leukemia, patients have to have both criteria, that there's 20% plasma cells in the blood, or they have a plasma cell count of at least 2. This is with a normal blood count of 4 to 10. So if 2 of that, or whatever that white blood count is, if 2 of that and or 20% of it is plasma cells, that's plasma cell leukemia. There's 2 flavors of that. There's the primary, which means people show up with it, with plasma cell leukemia, and secondary, when people who've had myeloma for 10 or 20 years and eventually gets very aggressive, and it happens late in the course of multiple myeloma. So for the primary, the kind that people show up with, it's 60% of the cases. It's younger ages. So the average age of myeloma is around, let's say, 70, and this happens younger, so in the 50s and early 60s on average. There's big spleen, enlarged lymph nodes. They have a smaller monoclonal protein. They don't have as many lytic lesions. They do have some of the same kinds of chromosome abnormalities that myeloma patients have, and you'll see some familiarity there. The secondaries are 40% of the cases, and there they call it a leukemic phase. So a patient had multiple myeloma, and then over time and over many, many treatments and maybe transplants and many treatments, and it finally just kind of escapes and gets very aggressive. It's an end stage. The average onset is a couple years, but it can be much later than that. And it's a very aggressive course. If there was a 17p deletion at abnormality, that can often happen with this progression. So better with bortezomib, that horrible drug that causes neuropathy. It turns out that the outcomes are better for this, for the patients who have it. So here's an example that with bortezomib, 69% overall response rate versus 31% without it. The overall survival is, the average overall survival is 18 months in primary plasma cell leukemia and only 2 months in secondary plasma cell leukemia. People do better who have bone marrow transplants, and here you can see this upper curve. This is with a transplant, the survival curve. To the left is always worse. That means it's dropping down really quickly without a transplant, the survival of plasma cell leukemia. So better with a transplant. Transplant, there was a median of 31 months versus less than 16 months without. They've done those same gene expression profiles that you heard about earlier today, and they can actually see what kinds of genes are present in the plasma cell leukemia. They've done whole exome sequencing, that's that WES down here, and mutation analysis. They can find that the cancer driver genes, you heard about driver genes earlier from Dr. Davies, so, and also Dr. Van Ness who talked about different cancer genes. So they can actually look and see the different kinds of genes that are expressed in these plasma cell leukemias. The treatment of secondary plasma cell leukemia, it's a very poor prognosis. When we give like the usual starting treatment with bortezomib, lenalidomide, dexamethasone, your VRD type treatment, overall response rate is 44%, but the median progression-free survival is only 5 months, and that's 2 months for refractory and 12 months for responders. So this is a really, really progressive thing. So this is what the question is that what is the worst kind of myeloma you can think of, and then what can you do about it? So that's where we are with this. In terms of the outcomes, if you go to a transplant, if you treat with chemotherapy and then go to autologous transplant, the complete remissions can be achieved, and the overall survival was 25 months for plasma cell leukemia versus 62 months for myeloma in this comparison. And the progression-free survival was only 14 months for plasma cell leukemia versus 27 months for myeloma in this particular study from 2010. There's a prospective IFM study. This is the French National Cooperative Group. And the median overall survival was 36 months, progression-free 15 months. So pretty much about the same. And this is just showing like how overall survival after an autologous transplant in this particular study for a myeloma versus plasma cell leukemia, so worse, even with transplant. So the IMWG algorithm to treat primary plasma cell leukemia, and then they also included what they thought the response criteria should be. So what they're suggesting is that patient have a bortezomib, again, neuropathy type drug based induction regimen. So, and see how we're using like the 7-drug regimen or hyper-CVAD, these kinds of multi-agent regimens. For a young person under age 50, consider myeloablative allogeneic transplant has been proposed here. That's like the full dose allogeneic transplant that we rarely do for usual myeloma. For over age 50, autologous transplant, and if the patients have a suitable donor, then a reduced intensity allogeneic transplant. So the idea here would be this would be one of those situations that we think should be considered for incorporating allogeneic transplant. And then for non-transplant candidates, an intensive regimen, and then clinical trials. So our summary points for plasma cell leukemia is that they're aggressive, they're worse survival if they're secondary, so after someone already has myeloma and then develops plasma cell leukemia. The treatment involves multi-agent chemotherapy and then transplant. Okay, so what's my pictorial representation for extramedullary plasmacytoma? So it's good that we're going to have Halloween in a few weeks. So anyway, so I can show a skeleton. So this this is the skeleton, and the bone marrow that's active in adults is in the skull, and it's in the sternum and the ribs, vertebral bodies in the spine, and then in the iliac crests and the proximal femurs might have active bone marrow here, the ribs. And what happens, and that's usually where myeloma is living, in those types of areas, but what happens in extramedullary plasmacytoma is that this plasma cell tumor is outside of the skeleton, so it's outside. And this is the most dramatic case that I have ever had over like 30 years of seeing myeloma patients, and I just couldn't believe it when I got a call. So a patient of mine had shortness of breath, went and had a chest CT scan, and I got a call saying, Dr. Becker, your patient has an 8 by 5 centimeter mass in their right atrium. And we did somehow get this biopsied, and it was plasmacytoma. So I've had plasmacytomas be in the liver of, once I didn't believe that they were in the liver, and I found that that my patient did have multiple plasmacytomas in the liver. So these are actually invading vital organs sometimes. Plasmacytomas can be anywhere, and we're most used to them being in the bones or closely associated with the bones, so they can kind of grow out of the vertebral bodies of the spine or be near them. They can kind of make masses associated with the skull, so they can be nearby, and they're actually better off. It's better off when they're nearby those places and not invading vital organs. And then in some places, they actually have good prognosis. So if they're in the gastrointestinal tract and they can be completely removed and then treated with radiation, those can have actually very good prognosis. It's not all the time that we end up with a poor prognosis situation. But the case of this patient was that what happened was the patient had a couple autologous stem cell transplants. And what happens sometimes after that is that there's a relapse with multiple plasmacytomas. And sometimes even this happens even at diagnosis, where there's just multiple plasmacytomas and they kind of just keep growing everywhere. And that's a different kind of a situation. So here was one study of the extramedullary plasmacytomas. It was a retrospective study. It was like it was an international study in 226 patients. And they found that the complete remission rate was better for these paraosseous, means around the bone, versus the extramedullary. So the complete remission rate was higher, 34% versus 19% in these only extramedullary people. But in relapse, this is what part of the problem is that in relapse, 54% remission versus 9%. So for the people who relapsed with these masses everywhere, only 9% complete remission. The overall survival was better for the people whose masses were near the skeleton compared to extramedullary at diagnosis. And extramedullary plasmacytoma at relapse had the worst prognosis. Progression-free survival was only 13 months. Overall survival only 11. So again, this extramedullary plasmacytoma was poor. Patients benefited from a frontline autologous stem cell transplant. So transplants still help those patients. Okay. So then this was a study, also multi-center, just published this year, in 127 patients, and this was retrospective. They took a look at the patients, and this is like with modern drugs. So they said, well, who developed this? They called this entity hematogenous extramedullary relapse and multiple myeloma. They called it HEMM. Hematogenous means it was bloodborne. So they think that people, that the cells went through the bloodstream to sit in these various locations. They said that 87% had a prior IMiD, 67% had a prior IMiD, and a proteasome inhibitor. The sites, 29% were skin-associated, 25% were lung, pleuras lining around the lung. And the overall response rate to all the different drugs that we have available today was about 57%. What they identified, and this was like the cumulative incidence of how many years it was from when they were diagnosed. So you see it just keeps going up here during these years. And then here on the right-hand side, what this is showing is what happened with in these different conditions. So the top one is showing if the patients had unfavorable cytogenetics. very poor survival. If the patients down here achieved a complete remission or a very good partial remission, they did much better than if they had just a partial response or progressive disease. They did much worse. So it's identifying the patients who have this HEMM entity and how they did. Worse with worse cytogenetics and worse if they didn't get a VGPR or better. So what can we do for all those folks? So it turns out that back in January 2015, President Obama declared that he would now have a precision medicine initiative. This would now be the case in the United States. That it would enable a new era of medicine through research, technology, and policies, empower patients, researchers, providers to work together toward development of individualized care. Doesn't that sound wonderful? So the traditional precision medicine that was carried out, that has been carried out, was that someone would find a mutation, as you heard about earlier, you'd get your inhibitor drug, and you heard about some of these approaches. And the prototype was the National Cancer Institute MATCH trial, Matched Molecular Analysis for Therapy Choice. You heard about some of this already today, but Greg said it's okay if we were repetitive. Anyway, so we've got a basket trial or a bucket trial or umbrella trial is what was the terms used to describe these. And this year, the MATCH trial had these were the arms and these were the genetic changes identified, and these were the drugs that we had available. So this was what the tools were. And the problem is that there's too few drugs, and then there's also little response. So let's say oops, sorry about that. Backwards, please. Okay, so 2017, when all this started, 6,400 patients were enrolled, and that means that all those patients underwent testing. And 983, 15% were found to have a mutation in one of the key genes, but only 10% of the patients tested actually were given a drug. 660 were treated. And the problem is that if you go by the different arms on the trial, so for example, here we have arm W, it's an FGFR mutation, so this is something that we think that it should work, where 70 patients had that, and it was 1.3% of the patients who were tested. And then the patients that were treated were 52 of those. And 50, so here's the 50 patients that ended up getting the treatment, and they had a 6-month progression-free survival. And only 2 partial responses. So that's like when we're giving targeted therapy. This is how poorly it's actually working. So here we have arm I. This was the American Society for Clinical Oncology meeting in 2018. This one was arm I, where there was a PI3 kinase mutation, 65 patients, 6-month progression-free survival, 27%, and no responses. They found, as we might surmise, that there were other mutations in those patients. So what makes us think that if we find one mutation that we happen to have a drug in our pocket for, but the tumors have hundreds or thousands of mutations, why would that one drug work? So this is a problem. The most successful is the one you heard about earlier, the BRAF V600E mutation. 35 patients had that with an overall response rate of 33% and median progression-free survival of 11 months. So that was the most successful one that there has been so far in this MATCH trial. So the limitations of genomics is that if we only have targeted drugs for certain mutations in specific cancer types, then that's not good enough. If there's multiple mutations in each cancer, then how do we know which one to target? The way I describe this is, how do we know which one is the Achilles heel, which one is going to be the domino that's going to make the whole tumor fail? We don't know what those are. And the other issue is that there's acquisition of drug resistance. So there's additional mutations. So we throw the first initial therapy at a patient, and then the cells that survive and grow back later have additional mutations, or they develop a pump to exclude the drug. So for relapse refractory myeloma, the other issue is that a patient comes in and you say, well, gee, you have all the, you have X% in your bone marrow, or you have this plasmacytoma somewhere, And I can choose one of these regimens for you, but we don't know which one should we be giving to what patient, right? Your doctor's making this decision. All that we've been talking about today is, oh, you go to your doctor who's a myeloma specialist because they know enough in their brain that they can figure out what you need. But actually, shouldn't there be a more systematic way of doing this rather than just going to the next triple drug therapy, or shouldn't we be able to try to match better to individual patients? So the way myself and my colleagues have been thinking about this, I've been thinking about it this way for a long time, is that we should have comprehensive precision medicine, which is multi-omic. You heard a little bit, somebody said those words earlier today, where we've got genomics and epigenetics and gene expression as a transcriptome, and proteomics, which is the way the proteins are, metabolomics, the way that the cancer cells metabolize drugs, and another one that I can't think of an omic for, which is called functional screening. So it's very accepted that you do antibiotic susceptibility testing. So we have here a plate, and there's a lawn of bacteria on it, and we drop these discs of the different antibiotics, and then we see clearing around the antibiotic disc, and then the one that clears the best and the most completely, that's the drug that your doctor gives you for your urinary tract infection or your pneumonia or whatever. So we accepted that decades ago, and the question is, why can't we just do that for your cancer? So here's a familiar face. So Dr. Tony Blau and our colleague Vivian Oler, and so we together, we started doing this 10 years ago. And the first diagnosis that we did this for was acute myeloid leukemia, and we developed an assay that is conducted at the Quellis core facility down at the Institute for Stem Cell and Regenerative Medicine at the University of Washington. And the test has been CLIA approved, meaning the state has approved it for use in patients. It's been CLIA approved for 4 years. So we can actually take patients have sent us their specimens from all over the world, and they can pay for the test to be done, or it can be done in a clinical trial. And we take their specimen and we plate it out, and we test. We have different custom panels for different diagnoses. So we have 150 drugs and drug combinations for acute myeloid or acute lymphoblastic leukemia. We have 176 drugs and drug combinations for myeloma, and we have 44 drugs for chronic myelogenous leukemia. We test them in plates that look like this. They have 384 wells. And then we add a reagent to see if the cell survived or died during a 72-hour incubation. And it's colorimetric, so we can put this into a machine that can read out the values. We calculate, and we get a panel of drug sensitivity curves. So here, for example, this is first my laboratory purifies the cells. So here this is showing that patient cells are 96.6% purified in my laboratory with magnetic beads. In this case, we did CD138, but we could also do BCMA. And we purify the cells, and then we test. And here are drugs that we typically use in myeloma. So you already saw this curve earlier, the Velcade curve, but we can actually do this for a whole lot of different drugs. And these are drugs that we use in myeloma. So for example, for this patient, the red line here is carfilzomib, and this yellow line is dexamethasone, and et cetera, et cetera. So one of the drugs here is melphalan is down here. So anyway, so we can check for which drug is best for you. So this led to a clinical trial, and one of my colleagues calls this pick-a-drug trials. And you heard Dr. Andrew Cowan's name before. I've put his picture here, and Dr. David Coffey is doing the cell-free DNA mutation analysis. So here we are doing mutation analysis and drug testing. So we're trying to do this multi-omic or biomic so far, but we have also done a little bit of the gene expression testing too, the transcriptome work. So this is an ongoing clinical trial, individualized treatment for relapsed refractory myeloma based on high throughput drug sensitivity genomics data. So some of the patients who relapse after the CAR T cell infusions, or some of the patients who we can never get a remission, so we can't even get them to an autologous transplant. Some of those patients who are growing those big plasma cell tumors everywhere, those patients are the ones that we can try with this kind of an approach. These are the drugs that we had. We are constantly swapping out and adding all the new drugs, so every time we think of something, we just add it. So, and this is just showing that every single patient is testing differently. So each patient is here. All these numbers are different patient numbers. Here are the drugs that look more familiar to you in terms of what's been used in myeloma. And every single patient has a little bit different drug sensitivity. And that's kind of expanded here, where you can see a lot more drugs. Red means that the patients are sensitive, and blue, the dark blue, means that they were resistant. So you can see here that every single patient looks completely different. And of course that makes sense, but yet what happens when everybody shows up to their doctor for the first time? What drug? 3 drugs do they get given for new diagnosis? They all get the same drugs, right? Exactly. So so the question is, why are we throwing the same drugs on everybody when everybody's tumor might be different? So anyway, so this is our current approach. So the other thing that we're doing in the lab is we're doing a combination trial. So we have a trial that we're doing in the patient. So all the patients get the drugs, so triple drugs. And at the same time, it's what we call a correlative study. We're doing in vitro drug testing in my laboratory. And we're trying to figure out whether there's a certain numerical value for drug sensitivity that correlates with clinical response in a patient. Or what if we demonstrate synergy? So formal synergy testing is being done in this trial as well. And we actually can see that one drug kind of helps the other, and together they work even better. So that's what synergy means, and that's what we're finding in the patient samples. And I think this is the best way of showing it. So if you look here at these curves, so here this is panobinostat. And as the curves go to the left, that means that they're more sensitive, then you get more cell killing. And so this is increasing concentrations of carfilzomib with panobinostat, and the curves are shifting to the left. So it happened in this patient, it happened in this patient, it happened here with panobinostat and dexamethasone, but did not happen here in this patient with panobinostat and dexamethasone, only happened with carfilzomib and panobinostat. So you can see sometimes there's synergy and sometimes there's not synergy. And maybe it's synergy that will determine how those triple drug regimens will work. So in the future, we envision that there's infinite drug choices and combinations. And this was here in Seattle, there was a Japanese artist, Yayoi Kusuma, whose art was exhibited here in 2017. And you would walk into these little rooms, and this was done by mirrors, the Infinity Mirrors exhibit, and you can see that there just is infinite in terms of, and so we hope that in the future we'll have these infinite drugs available and drug combinations for every single patient based on their sensitivity testing. So a conclusion and the future, we talked about that the application of rapid molecular and functional screening to choice of treatment, I forgot to mention, so we get results on this in 5 days for patients. We give them drugs. We can choose drugs for them within 5 days. This is feasible, and that I believe the future, that data on the clinical features, the mutations, the drug sensitivity, the gene expression responses will contribute to a future algorithm to optimize precision medicine approaches to cancer therapy. We've already been working in acute myeloid leukemia for the full time of the 10 years, and we've made tremendous strides, and we've got machine learning algorithms that's helping figure out the gene expression for 17,000 genes. How does that predict drug sensitivity? And there's no reason we can't do that for myeloma as well. So this is we believe this is another potential tool for the future. I tried to swap out my talk and my acknowledgement slide, and was in the one I swapped out, and this is not the one that got opened. So anyway, maybe I can open the right one and put my acknowledgement slide in here while we're doing our panel discussion, if that's okay. So thank you so much for your attention. Thank you.